see our absolute rate of infections in our primary hip and knee replacements is less than 1%, which is fairly consistent with what other people report in the literature. And there's really no difference between when we provide our patients general or spinal anesthesia. When you compare that to the group in Taiwan, it's clear that, number one, they have a higher reported overall rate of infections. That may be due to an absolute overall higher rate of infections, or possibly they survey differently than we do. In basic terms, their method of surveying is similar to what ours is, but there may be difference in the details. But suffice to say, in their hands, possibly general anesthesia is different than spinal anesthesia. But I think you can see in our hands there really is no significant difference. And I think the importance of this is when someone else in their setting promotes a possible change to your practice, you need to understand for yourself specifically, does that really promote better outcomes in your hands? And I would say that in Taiwan, maybe they should do spinal anesthesia. But at least at the main medical center, there doesn't appear to be any significant difference. So before we change our practice, we're going to wait for more meaningful and significant information than a retrospective review from another group. We do provide feedback to our providers. Each of us gets our information for self-reflection. The other way that information can be provided is what we call consequential. And what I mean by consequential is when you provide somebody some comparison that might be used in some way that might have a negative impact on that specific provider. That's not a manner in which we use our information. We don't think that we can compare different providers because we don't think that any one of us does enough cases, that we can do adequate risk stratification to allow for a statistically valid comparison. So as a result, we don't use direct provider comparisons, and we certainly discourage other groups from using quality assurance data in that manner. What we use it for is for self-reflection. What we do is we provide each of us our own and the group outcome rates so that they can compare themselves to the overall group. It does allow you a modicum of risk stratification because we provide the information specific to the site of service. So, for example, if I go out to an outpatient surgery center for orthopedics, I can feel comforted that I'm comparing my own outcomes to my other colleagues who are in the same setting. We do provide it by type of case, type of anesthetics, and we also allow comparison of compliance with protocols. That allows each provider to develop a hypothesis that they can test over time using trends. This is an example of that. Unfortunately, this is me. This is my own report. In 2006, I noticed in my self-reflection that my incidence of vomiting at the outpatient center I practiced at was really significantly higher than my colleagues. I, like many people, my first reaction to this was denial. But when it came back in 2007, still higher, I had to recognize that I think I'm different than my colleagues, but just like anybody else, I want to be a winner. So I went back and asked myself, what am I doing differently than my colleagues are doing? And I think the one thing that stuck out to me was the fact that I used nitrous oxide. I thought I was doing my patients a favor by getting them out of the recovery room sooner. But I, in reflecting, felt maybe it was contributing to this increased vomiting. I eliminated that from my practice, and as you can see over time, I've been able to reduce the experience of vomiting in my patients to much more consistent with my colleagues. Parenthetically, I also do track how my patients are doing in terms of their times to discharge, and that hasn't worsened. And so I think overall I'm providing better care to my patients, and this has been very useful to me. And many of my colleagues have had similar experiences with their own provider self-reflections. We do use the information in OPPE and FPPE. However, there's a proviso. We only use guideline and process compliance in those processes because they do have potential negative consequences. You need to pass OPPE and FPPE to keep your privileges, so you can imagine that there would be significant consequences if your measures didn't meet those standards. So because of that, we only use things that are completely within our control. Those things are our process and compliance with the quality assurance database. It does allow us to do direct comparisons between providers because each one of us is responsible for completing the data form. There's nothing about the patient that prevents me from completing the data form, so it's entirely under my control. And if I want to meet that standard, I can do it rather easily. This is an example of our practice and how we do. I think, as you can see, there are some of my partners who are on the lower end of the spectrum. This is the first year that we've begun to incorporate this into our credentialing and privileging process. And I can tell you that the first time some of these providers came through, they were advised that their number was low, that they would be remonitored in 6 months. And I can tell you quite gratefully that every one of them at the 6-month mark has met the standard that they need to, and that nobody has suffered any negative consequences as a result. This is powerful, though, because when JCO comes through and they want to monitor us for our peer review credentialing process, they want provider-specific measures. This allows us to show them that we give provider-specific feedback and that providers are held to a standard. They're very satisfied with that and very happy with that. We anticipate that we'll be using this to meet our MOCA requirements. Obviously, this is a moving target, but at least at the last time I reviewed the website, there will be a requirement that all diplomates must meet both the PPAI activities over their 10-year cycle. That includes both the case evaluation process as well as the simulation education process. This is what's entailed in the case evaluation process, and it involves collecting, comparing data, implementing a plan, and reevaluating that data. The examples that were originally listed are nausea, vomiting, hypothermia, and blood glucose. I think you can see very quickly that my example of self-reflection would certainly fit very nicely into that MOCA process, and that quite easily we could use our quality assurance data to meet those MOCA requirements. I think that's going to be a great relief to all of my partners who want to participate in MOCA and maintain our boards. The last way in which we anticipate using our data is registry participation. There are a whole host of societies that are beginning to make registries available to our membership. AQI, SAMBA, PEAS. There are also private organizations like the Large Anesthesia Business Group that are providing availability for registration. I think that these are going to be powerful tools for us going into the future. It's going to allow us to make comparisons between other people of like practices, of like minds. It's comforting to know that many of these organizations are run by anesthesiologists and that they will be in control of how the information is utilized. Hopefully we'll be able to validate our findings by making these comparisons, and hopefully it'll allow us to participate in CMS PQRI programs through registry participation as opposed to through billing participation. So I'd like to close by just reminding everybody the basic tenet of quality assurance, and hopefully you recognize this in almost everything that we do. You've got to be able to measure your quality indicators. You have to develop a hypothesis, you have to act on your hypothesis, and then you've got to be able to remeasure it. That all suggests to me that you need to have a continuous way to collect your information and monitor your information. And then the last thing I'd like to close with is that a quote from Albert Einstein, not everything that can be counted counts, and not everything that counts can be counted. And what I mean by that is that many people want us to judge ourselves and our colleagues simply by the outcomes that we incur, and sometimes you can't put a number on quality. Quality is a subjective assessment. It's always going to be a subjective assessment, but quality assurance data can allow you to improve your practice and hopefully subjectively demonstrate that you are a better practice. Thank you for your time today, and I'll entertain any questions.